Hi, good afternoon, everyone, and welcome to another class for exercise testing and prescription for clinical. Today we're on Chapter 9, and Chapter 9 is going to cover a little bit more into the special populations group. Now, this chapter does get a little redundant with previous chapters. When you guys go to update your highlights in the book, you'll notice that the first section's dealing with cardiac rehabilitation, and we've already covered that a lot in previous sections, as well as the exercise prescription. Therefore, I've taken that out of today's lecture. However, you will be still responsible for the stuff that's in the book regarding the cardiac rehabilitation side. So what we're going to do is we're going to cover parts beyond that. Now, the overall theme of today's lecture, which will be relatively short, by the way, is more so on the acute basis. When I say that, I'm talking about inpatient and then immediately outpatient, and how exercise prescription will look like in those scenarios. So what we're going to cover is sternotomy, patients that have a pacemaker, cardiac transplant, stroke, peripheral artery disease, and then also, lastly, pulmonary disease. Now, here is the thing about these guidelines. There are no set guidelines when it comes to exercise prescription with these, mainly because it's hard to actually study these individuals that have pathological issues, because there is an issue with mortality in these experimental designs. So therefore, the book uses sound logic to provide exercise guidelines. And you'll notice that those guidelines are very similar to what you know as from previous sections, from the normal adult to even some of the earlier pathological aspects. You guys as practitioners, especially if you're going into physical therapy school, physician's assistant, occupational therapy, or even if you're going to be a personal trainer who has to deal with individuals as such, it's always a good idea to refer back to the guidelines in this book to set the basis of how you would structure exercise for those individuals or those special populations. So let's first start with talking about with patients with sternotomy. Now, sternotomy is, I know that picture is kind of gross, but it does give you guys an idea of what's occurring. Sternotomy is simply just an incision in the sternum, and what it's used for, if you notice how the clamps in the picture is pulling the sternum as well as the ribs apart, it's used to access both the lungs and the heart for a multitude of different surgeries, whether it's a heart transplant, a pacemaker, or what have you. Now, individuals with sternotomy typically have an underlying issue as well, so you got to keep that in mind when you start creating exercise programs, and we'll get into that a little later. So most patients with sternotomy can actually heal within about 8 to 10 weeks. However, what it is when individuals have that particular procedure done, it's wires that are actually holding the bones together to get them to fuse. Now, with that said, you're going to have to restrict a lot of different movements for those specific individuals. For instance, you're ideally going to want to limit upper body mobility, such as thoracic mobility exercise, which probably would encompass a good amount of overall upper body exercises in general. Now, based off the ACM guidelines, and they're using the best practice in terms of logical basis, typically individuals who have that particular treatment are only going to limit their lifting load to anywhere from 5 to 10 pounds for about 10 to 12 weeks. Now, moving on to individuals with pacemaker. Now, to get a pacemaker installed at the same time, you would also have a sternotomy procedure done on the heart. So therefore, some of those things that apply will also apply here. Now, as you guys may know, the pacemaker is an automated device that's implanted in the heart, and it's there to keep the normal rhythm. In some instance, the rhythm of the heart, there's some kind of blockage within the bundle branches that creates an unsynchronized contraction between the atrial and also the ventricles. And the pacemaker helps to accommodate that. Pacemakers, when you're thinking about exercise considerations, it's programmed. It's a programmed node to control heart rate and heart rate limits. Now, whenever you're doing exercise with an individual with a pacemaker, you want to take into consideration testing procedures. You want to test whether or not that pacemaker is increasing its rate as an individual's level of intensity goes up. As it says there in blue, you don't want to continue an exercise program if the intensity or the level of the exercise continues to rise, but heart rate doesn't. That means there's something going on with that particular pacemaker. Now, when there is a defibrillator implanted in the pacemaker itself, per guidelines, it's warranted that the max heart rate or the peak heart rate of that exercise is about 10 to 15 units below the programmed heart rate to account for the heart going into a fast heart rate or tachycardia. Now moving on to heart transplant or cardiac transplant. Again, the rules or the guidelines that apply to sternotomy also apply here. So, believe it or not, I have had clients who had heart transplants. They are uncommon, but you never know, you might actually have an individual who has one. And approximately about 4,000 people in the United States have them, with a good amount of survival rate from 75 to 81. And in some cases, they can improve VO2 max. Whenever you're considering, though, individuals who have a cardiac transplant or a heart transplant, when you do exercise testing, typically their peak VO2 or cardiac output is going to be reduced by 20 to 35%. Therefore, their exercise capacity is going to be depressed quite significantly. Now, compared to age-matched individuals, typically their resting heart rate is higher. Additionally, however, their heart rate response is actually somewhat attenuated. So the higher the intensity, their heart rate does not go up as much. Lastly, though, to accommodate with that or to follow that, heart rate recovery is somewhat slower. So they're actually showing depressed signs of cardiac ability. Now, again, also with exercise testing, something to consider is that also compared to age-matched healthy individuals, blood pressure is typically elevated at rest as well. When you're considering doing testing on individuals who have just had a transplant, you can without a doubt do an exercise test protocol. In fact, the ACSM provides that we do something called the Naughton or modified Naughton protocol. And if you guys remember, we did talk about this in chapter 5. It is very similar to a Bruce protocol, if you guys can remember the steps going up or the levels going up on a treadmill. However, the stages are less intense. If you look over here at the grade, the speed is rather slow. And the intensities or the grades, they do go up to a good amount, but nothing that's too fast. And that is a way to get an understanding of where that individual's cardiorespiratory function is after a cardiac transplant. Keep in mind, this might actually be done after outpatient. And now let's apply some of the FIT recommendations. Notice that the FIT recommendations are somewhat very similar to that of normal adults. However, they might be attenuated in some cases. For instance, RPE is probably going to be a little bit lower. Resistance training is also going to be a little bit lower with perhaps even lower weight. In this particular instance, this would have to be after that 10 to 12 week period, after that sternotomy procedure has healed. And again, we have the time and the type. I think the only thing here that differs from typical guidelines is the time, where it's 15 to 20 minutes up to maybe 30 to 60, whereas the minimum for healthy adults, perhaps in the same age group, is anywhere from 60 to 90 minutes. Now, after cardiac transplant is done and they are fully healed, you might be somewhat hesitant to actually push these individuals. Believe it or not, there have been many studies to show that high-intensity interval training has been used with cardiac transplants up to 90% of the VO2 max, which is actually pretty challenging. And it does show some objective truths about that, of using high-intensity interval training for improving exercise function. Now again, going back to individual sternotomy, you're going to want to restrict any upper body movements, like perhaps bench press, shoulder press, anything that's going to have them to thoracically extend at the chest. Now let's go on with individuals with peripheral artery disease. Notably, when we consider all these diseases, they typically have an underlying mechanism, perhaps even more, or they are comorbid, meaning they both have diabetes, cardiovascular disease, maybe even pulmonary disease. And sometimes these are they are associated with one another. Now, peripheral artery disease is usually accompanied with what we know as claudication. And claudication is pain in the lower legs. And the reason why that pain is because there's some kind of buildup or atherosclerosis that's causing a shunt inside the lower legs. Now the reason why that's problematic is because that particular, if that individual were to cut the lower part of their leg, sometimes the healing process on that is very much attenuated, or if it's very severe, sometimes they have to get lower limbs amputated. So therefore, these individuals actually benefit greatly from exercise, even more so cardiovascular. And as you notice, the guidelines for the FIT recommendations pretty much outline are the same across the board, which is why I'm not going to delve into it too much. However, as practitioners, you're going to use your best judgment based off the severity of the pathology, and typically you're going to use the Borg scale to get an understanding of how hard you want to push that individual. Now, almost done with this particular lecture, but now let's consider stroke. And I'm sure some of you guys know individuals who've had strokes, but they can, without a doubt, still come back to normal functioning, just depending on where that stroke occurred. In fact, one of the world's strongest men recently had a stroke. Hafthor Bjornsson, you guys may know him as the Nun. He actually had a stroke on his face, and it destroyed some of the nerve cells in his brain. Now he can't move half of his face, but yet he can still lift a good amount of weight. So like I was saying, a stroke is pretty much an obstruction within the arteries in your brain, and it causes some kind of cell death. And as such, individuals, depending on the area of where that obstruction occurred, they can have cognitive impairments, but also depressed motor abilities, maybe in the right or left side of their bodies. And that's typically what you'll see. Maybe some right side of the body is impaired, which can lead to some areas where it might be hard to do testing. Now you can still test, but you're going to have to be creative with the test that you pick. In fact, in a lot of ways, stroke patients happen to be some of the elderly, unfortunately. You can still do a senior fitness test on an individual, except you would modify it. Essentially, you're going to want to look for those pre and post changes to see if that individual is getting better off your modified test. And you can basically do that with any test. One of the contraindications, though, for when you're thinking about exercise testing is avoiding the Valsalva maneuver. Now, we all know Valsalva maneuver is it's trying to create intra-abdominal pressure, and what that does is it helps with stability. For those of you who squat heavy, you'll know that you'll do this naturally. You'll typically hold your breath or push your air out against the closed glottis, and it helps create that pressure. But at the same time, it creates peripheral pressure within your peripheral vessels, and you don't want to do that with an individual who has had a stroke or who is recovering from a stroke in the acute sense. So one of our principles that we learn about is specificity. You want to employ specificity to that individual. And a lot of times these individuals are just wanting to return back to work. So therefore you want to strengthen or try to get those motor patterns back to where they can still function with their daily activities or the ones that they did at work. Now on the last section covering pulmonary disease. Pulmonary disease constitutes a lot of diseases or a lot of morbidities as a subcategory. For instance, you have COPD, and COPD can include chronic bronchitis, emphysema, and asthma. You also have restrictive lung disease and so forth, even lung cancer. And what I'm going to do is I'm going to lump these together because the fit prescription are typically the same across the board. Now, I'm pretty sure some of us know, or all of us know what asthma is. It's basically a limitation of the airflow that is done by some kind of bronchial constriction. Now, the thing is with asthma, when you're thinking about exercise or even exercise testing, it can be exercise induced. In fact, I used to have exercise induced asthma as a child. And in some cases, when you're doing your testing, you have to consider that. If an individual does have known asthma, you also still want to test to see what limitations they have when you're actually doing your training. However, you want to consider for that individual to always have their dilator with them before you start that testing. And if you notice here, the recommendations are, again, they're still pretty much similar across the board. As I said before, special considerations, you always want to make sure that they have their dilation. Another thing too, somebody who's just been diagnosed with exercise-induced asthma, a lot of times they have to take some kind of corticosteroid. These corticosteroids, in fact, you're looking at one called clenbuterol, and usually they end with some kind of buterol. They actually help to ramp up metabolic rate in a lot of cases. Sometimes peripheral muscle wasting is a known sign for individuals who have asthma because it ramps it up so much. If it's not accounted for with stress to the muscle, as well as dietary intake, a muscle wasting can be seen. But those things can be prevented from resistance training. Now again, COPD is actually one of the leading causes of death throughout the world. And I'm sure some of us know an individual who has COPD, but it encompasses asthma as well as emphysema and chronic bronchitis. And some of the signs of that is a chronic cough and sputum, which is another way of saying mucus, and also dyspnea, which is shortness of breath. Now again, you can still test individuals who have COPD, and usually it's going to be an incremental exercise test. Typically, anybody who I've ever had as an exercise test with COPD always did just a 6-minute walk test or a shuttle walk. And you can check the guidelines for both of these in earlier parts of the chapter, where where an individual, for instance, a shuttle walk, where an individual would stop would give us an indication of where that individual's VO2 max is. And yet again, here are the recommendations. Notice the similarities between all of the areas. Again, like I said before, there is no set guidelines because the data is just not there to support it. And rightly so, because it would be very unethical to perform those kind of procedures, especially if somebody who is nearly going to die. So therefore, we have to use our best judgment. Use your best judgment as practitioners and use some of these guidelines to help you protect the client, patient, but also yourself so you don't get in trouble if something were to happen. Guys, that concludes this particular lecture. It was real short, again, because of the similarities between past lectures. And yet again, because there are no specific guidelines to this as far as scientific data shown. With that said, that concludes this lecture. However, don't forget to update your notebooks from the highlighted sections in Chapter 9. Thank you.